Assalamu alaikum wa rahmatullahi wa barakatuhu, and a very good evening to everyone. I am Dr. Kanza Ahmed Chandio, the CEO of Experience Dentistry, and it is my absolute honor to welcome you all once again to Pakistan's one of a kind virtual summit on maxillofacial fracture. This summit makes a significant milestone not just for us at Experience Dentistry, but for the entire dental and medical community. In Pakistan, events like these are rare, and this platform is designed to bridge that gap between the clinical expertise and public awareness. Let us shed some light on why this summit is important. Maxillofacial fractures are not just surgical challenges, they are often life altering injuries that require a multidisciplinary approach for effective diagnosis, management, and rehabilitation. This event holds immense value for dental students who will gain exposure to real world trauma case and understand surgical considerations beyond routine dentistry. For general dentists, who often are the first point of contact and must be equipped to recognize and refer these cases promptly. The general physicians, especially those working in emergency care who play a critical role in early management of facial injuries, and, of course, the public, who need to be more aware on how facial trauma occur, how it can be prevented, and what treatment options are available. We are proud to bring together an esteemed panel of speakers and experts who will share insights from both clinical and academic perspectives. Our goal is to foster understanding, encourage collaboration, and spark a deeper communication to oral and maxillofacial health in Pakistan and beyond. Once again, thank you all for being here, and I look forward to a productive and enlightening session. Let us begin the session. Ms. Laiba, the stage is yours.
Thank you so much, Dr. Kanza. So, Assalamu alaikum everyone, and a very good evening. My name is Laib Iftikhar. I am liaison officer of Experience Dentistry. Today, we'll be starting day one of Maxillofacial Fractures Virtual Summit 2025, hosted by Experience Dentistry. Our first lecture is by esteemed international speaker Dr. Mariam Mostafa. Dr. Mariam is the founder of Luceat, a journal dental practitioner, educator, and content creator based in the United Arab Emirates. She graduated with high honors in dentistry from Misr International University, holds a master's degree in endodontics, and is passionate about making dental care simple, relatable, and empowering for patients worldwide. She blends her clinical expertise with a unique approach that focuses on patient confidence, education, and evidence based care. Today, she will be speaking on the topic dentoalveolar fractures, sharing her insights on diagnosis, management, and clinical pearls for achieving successful outcomes. We are truly honored to have Dr. Mariam with us today. Without further delay, I'd like to invite her to begin her presentation.
Dr. Leba, for this amazing introduction. I'm really honored to be here, and I hope you find this presentation informative and insightful. Let's start the presentation. Please, can you just tell me if the presentation appeared on your screen?
Yes.
Okay, perfect. So today we're going to talk about the dentoalveolar fracture beyond the tooth, diagnosing and managing it. Actually, my dental page, it's called Luceat, which means let it shine. My name is Dr. Mariam Mostafa, and today we're going to talk about the dentoalveolar fracture. Okay. Dental fracture, actually, the definition of the dental fracture, it's displacement, partial dislocation, or fracture of one or more teeth. Associated fractures of the surrounding alveolar bone can be associated with it. It can occur alone or with other facial bone slash soft tissue injuries. So sometimes only the fracture happens within the bone or within the bone and the soft tissue too. Okay. Most commonly, it happens in children more than adolescents, and it happens more often in males than the females, okay, with a ratio 3 to 1. The common causes are obviously the falls, accidents, sports injuries, and road traffic accidents. These are the most common causes that could cause the dental-alveolar fractures. Let's dive into the classifications that we're going to talk about today. Of course, we're going to dive into each one of them in details. How can we manage it, and the different types of each. Okay. The first one, it's called the dental hard tissue damage, which can come in the form of crown cracks or fractures with or without root involvement. The second one, it's actually periodontal injury. So, like its name, it actually requires, or it actually includes the periodontal tissue with it. Which sometimes it can come with the picture of concussion, subluxation, intrusion, extrusion, lateral luxation, and avulsion. Alveolar bone injuries. This comes in the form of tooth intrusion with fracture of the socket, alveolus, or jaw. Okay. So the alveolar bone injury and the periodontal injury, the difference between them is that the alveolar bone injury, it actually includes a fracture in the socket or the alveolus or the jaw itself. Okay. Then we're going to jump into the gingival injuries, which happens in the soft tissue mainly. Okay. The combined injuries, it is a mix of both traumas together, like any type of injuries in the above classifications. This is another classification that we're going to talk about too. Here we're going to talk about the infraction. Infraction, it actually it's a crack or like a trauma that happened to the crown, but no fracture happened within the enamel or anything. So there was no loss of tooth structure. Okay. Second one, which is a vertical or horizontal crown fracture, and this can actually be confined to the enamel, or it can be involved into the dentine too. It can involve the pulp with it, and it can come with a form of horizontal or vertical oblique involving the mesio-incisal or the disto-incisal angle with it. Okay. So the thing is that it happens with different pictures, and these are the different ones. Then we're going to jump into the crown root fracture. The crown root fracture, it can involve the pulp and it cannot involve the pulp according to the fracture again. Then we're going to jump into the horizontal root fracture, and horizontal root fracture, it is according to the site of the fracture. So whether it happens in the apical third, middle, or cervical third. Okay. Or sometimes the fracture can come vertically, okay, or horizontally. Then we're going to jump into the concussion. Concussion, it's kind of similar to the infraction, but this one, it kind of like moved a little bit. So it's just like a slight injury to the tooth supporting structure too. Okay. It can result in sensitivity to touch or percussion, but as I said, like there's no like a probable mobility or displacement, but like it's like kind of like worse than the infraction. Okay. Then we're going to jump into the mobility. When does the tooth become mobile? It becomes mobile when subluxation happens, or it becomes displaced when intrusion, extrusion, labial displacement, or lingual displacement happens. Of course, labial and lingual displacement most commonly involves the fracture in the alveolar bone too. Okay. Avulsion, it means a complete displacement of the tooth from its socket, and again, this may involve the alveolar wall or it may not. Okay. Then we're going to jump into the last one, which is called alveolar process fracture. Okay, let's jump into the dental hard tissue injuries. These injuries arise from either from a direct blow to the teeth or from forceful collision between the upper and lower teeth. So, for example, sometimes there's like a specific sports, for example, like kickboxing, MMA, things like that. Sometimes when the person takes like a direct blow to their teeth, this commonly affects the anterior teeth. Or maybe when this person get affected to an accident, like a real accident, and their condyles actually get fractured in the posterior teeth. So um, it's according to the cause of the trauma. Okay. Front teeth typically suffer damage from direct impact, as I said before, like a direct blow or things like that. Whereas the posterior teeth, they happen due to an indirect impact. For example, car accidents and things like that. Intrusion injuries are more common in the upper teeth, and impacts against the lower teeth can cause vertical fracture. A thorough clinical and radiographic assessment are crucial to accurately evaluate the extent of the dental trauma. So it's important to know the extent of the dental trauma, and afterwards you're going to decide your treatment accordingly. Okay. Of course, sometimes the patient comes with dental trauma, and we can call this that the tooth is in shock. So sometimes the tooth when it's in shock, you cannot decide if it's actually necrotic or not. So you have to just wait, or you have to do like an examination test, percussion test in the surrounding teeth too. Okay, when a tooth is missing or knocked out, maybe just check for a chest X-ray, because sometimes the patient aspirates this missing tooth. Treatment objectives. Expanded preservation of damaged teeth, it depends on a couple of points, and we're gonna discuss each one of them. The first one, which is complexity of the maxillofacial injury. It's according to whether this fracture is in the anterior region or in the posterior region, and it depends on if it involves the multiple facial bones or not. Okay, for example, the tooth preservation due to a compromised vascular supply and tissue stability may actually be worse than a simple localized dental alveolar fracture due to like the a vascular supply, because it's worse in the fracture when it involves the facial bones and things like that. Second, open apices, it can actually help you in the regenerative capacity. It has a better regenerative capacity, a richer blood supply, and a better healing capacity. So the prognosis of the patients with open apices or younger patients, it's better than the patients who are older or have like a narrower root canals, because the regenerative capacity will decrease when we get older. Third point is general dental condition. So sometimes the fractured tooth, it can actually have like caries in it, or periodontal involvement like gingivitis, periodontitis, etc., or previous trauma before. These three different points will affect the prognosis of the management of this teeth. Okay. Side of the injury. Of course, anterior region injuries, they're easier to stabilize and monitor, while the posterior fractures may be harder to assess and splint. Most probably, it may require surgeries in the posterior region, but the anterior region, most probably all general dentists may do it. It's fine. Fifth point, it is the patient's wishes. So the treatment plan, it should align with the age of the patient. It should align with the patient's aesthetics, functional expectations, tolerance for multiple visits, and complex rehabilitation. So whether the patient has a medical problem, this person is a geriatric dentist patient, or for example like a baby and things like that. So it's like it's according to the age of the patient mainly. Open root apices, I wrote this again just to highlight that the open apices will have a greater healing potential due to the enhanced revascularization capacity and better blood supply. Intact gingival tissue. Healthy gingival margins protect the fracture site from bacterial contamination and promote periodontal healing. Okay, so as we said before in the previous fracture, it's actually called concussion. So the concussion, the soft tissue, is the one who got the trauma, not the tooth itself, and this happens when you have an intact gingival tissue. So the gingival margin, it supports or protects the tooth from a fracture. Absence of root fracture. Root fractures significantly lower the prognosis due to the compromised structural integrity and increased infection risks. And this is an example of the horizontal root fracture. Periodontal bone support. Obviously, when the patient comes with a fracture in their anterior teeth, and this patient is young, their bone support is going to be really good. Their periodontal ligament is going to be better than the older ones, and their stability and splinting effectiveness, of course, it will be better. So the prognosis of this patient will be better than the patients who have, like, for example, recession, bone resorption, or recession, or periodontal issues, and things like that. Injuries to the primary dentition. Approximately 70% of injuries to the primary teeth affect the upper central incisors. The most frequent types of dental trauma, including intrusion, lateral luxation, and avulsion. Okay, have you asked yourself before, why do the upper central incisors are the most common teeth that can actually affect the trauma, or the trauma will affect it mainly? Because these are the first permanent this is the first permanent tooth to actually come into the dentition, of course, with the molar, but the molar is like in the posterior region. And most probably sometimes, like for example, we have like normal overjet and things like that. But with patients who have like increased overjet more than the normal, the trauma accidents will increase. So this is actually worse. Teeth that have been intruded often erupt naturally without intervention. Displacement of primary teeth can cause noticeable damage to the developing permanent teeth beneath. So we need to make sure about the permanent teeth beneath. Sometimes the permanent can erupt with a change in the color, or for example, hypoplasia, or things like that, like enamel, or like tooth and like anomalies. And this mainly happened due to the trauma of the primary teeth. So the first question when the patient comes with, for example, like a dark tooth in their permanent tooth and things like that, the first thing that I ask, like, did you fall before? If the patient told me, yeah, like when I was young, or things like that, and so this will be the main point that this patient can, like, the permanent tooth is actually affected because of it. Displacement of primary teeth can cause noticeable damage to the developing permanent teeth beneath. Treatment guidelines: teeth that are fractured, extruded, or severely displaced should be removed. Teeth with minor displacement and no interference with the bite should be carefully observed, or as extraction may pose risks to the underlying permanent teeth. So if I have to extract, maybe I could just space maintainer or things like that. Injuries to periodontal tissue. When force is distributed across multiple teeth or cushioned by soft tissue, possible outcomes include concussion, subluxation, intrusion, displacement, and avulsion or fracture of the tooth surface. Loosened or displaced teeth have a high risk of developing pulp necrosis. Similar to root fracture, possible long-term complications include external or internal root resorption, pulp canal obliteration, ankylosis, loss of alveolar bone. These are just some pictures for the dental trauma. This one is the concussion. As you can see, nothing is shown here. Subluxation, same exact thing, because the soft tissue is the one who got all the trauma, not the tooth itself. We have the extrusion here. The tooth itself, it moved from its socket. We have the lateral luxation, which means that the tooth itself, it got displaced medial or distal, and most commonly the bone itself, it will fracture the labial bone or the lingual bone. We have the intrusion, which means that the tooth itself, it got inside of the socket more than normal. Avulsion, it means that the complete loss of the tooth. We have here the infarction, which means that the crack happened in the side the tooth, but there is no fracture or anything. We have the enamel fracture, and we have the enamel fracture. The fracture is only confined in the enamel region. We have the enamel dentine fracture, and here the dentine is involved. And here we have the enamel dentine pulpo fracture, which means that the fracture actually involved the pulp with it. Then we have the crown root fractures. The first part is the crown fracture only. Here the root got involved with it. And as I said before in the previous slide, that the root fracture, it can happen in many different forms. For example, it can happen in the apical form, it can happen in the middle, or it can happen in the coronal third, or maybe vertical or horizontal fracture, or oblique, as we see here. Then we have here the alveolar fracture. Injuries to periodontal tissues. Management of periodontal tissue injuries, we have luxation and extrusion. Teeth that are loosened, laterally luxated, or extruded should be repositioned. So I need to reposition the tooth slowly. Of course, the patient will be in pain, but just try to do it fast. Then we're going to splint this tooth for 1 to 3 weeks using a semi-rigid splint, such as acid etch composite, arch bar, orthodontic wire, soft stainless steel wire loop, or vacuum form splint. I honestly personally use the acid etch composite, which is the easier like treatment option, and the arch bar too. It's really easy. Or orthodontic wire. So the first three, they're actually great. Avulsion requires immediate replantation following by semi-rigid splinting for 1 to 2 weeks. Of course, I'm just like kind of like highlighting the word semi-rigid, because if we use like the rigid splinting, or if the patient did not come after 1 to 2 weeks, or delayed the removal of the splint. Unfortunately, sometimes this tooth may be ankylosed within the bone. Prognosis depends on the stage of root formation. As I said before, open apices, it's better. Extraoral dry time, length of exposure. This usually is important when it comes to the avulsion, because we need to replant the tooth in less than 30 minutes. This is the best option. Storage medium before plantation, of course, the best storage medium, we can you just use like saline, milk, or things like that. But the best part is that you just replant the tooth inside the socket itself. Some doctors use saliva, but I personally use saline. Proper handling and splinting technique. Alveolar fracture. In the mandible, alveolar injuries typically involve a complete break in the tooth bearing region, whereas in the maxilla, these injuries often occur in isolation. Teeth may remain intact, but there is a significant risk of devitalization that should be anticipated. Alveolar fractures usually present as two separate fragments, each containing teeth. Though like more complex comminuted fracture can also occur. Comminuted fracture, it means that it actually involves not only the tooth. Okay. When alveolar fracture affect the mandible, they may coincide with a mandibular fracture. Similarly, impacted fracture in the maxilla can sometimes appear immobile. A midline split of the palate combined with a unilateral Le Fort 1 fracture can result in an extensive dentoalveolar fracture. Fractures of the maxillary tuberosity and the floor of the antrum are recognized complications following the extraction of upper molars. And this actually happened to one of my colleagues. They kind of like wanted to extract the upper molar, but it was kind of like a traumatic extraction, unfortunately, and maxillary tuberosity got fractured with it. But these complications happen, and the most important part is how to deal with the complication that you already did. Management protocol for alveolar bone injuries. We can use block or plate fractures. These are just two different points. Precise manual repositioning via finger manipulation. You can just use it with your hands. Closed reduction following by definitive stabilization or implantation of rigid wiring in conjunction with composite splinting to ensure firm fixation. Avoidance of premature dental contact and mitigation of occlusal trauma, employment of short duration intermaxillary fixation to facilitate optimal healing. Management of tuberosity fractures. Remove any comminuted fragments involving lost alveolar bone and teeth and carefully repair the surrounding soft tissues. Delay tooth extraction in cases of tuberosity fractures for a period of 6 to 8 weeks to allow for healing. Teeth involved in a block fracture must be extracted surgically as a mandatory procedure. Stabilize fractured tuberosity teeth by splinting them to adjacent healthy teeth for approximately 1 month to ensure proper support and healing. Sometimes injuries can affect the gums and surrounding soft tissues too. For example, lip trauma is more frequently seen with fractures involving the front teeth and alveolar bone. Fragments of teeth or foreign objects often become lodged within the soft tissue. Sometimes we find the lost fragment inside the lips itself, posing significant concerns. Gingival tears commonly accompany fractures of the dentoalveolar region. Deglobing injuries to the chin area are a typical consequence of a trauma to the lower front teeth. Management of soft tissue injuries. So we need to do a thorough examination of wounds and penetrate the full thickness of the tissue. Careful removal of dead tissue and extensive rinsing using chloroxidine solution. Extraction of any exposed damaged bony fragment. Surgical repair of the injured soft tissue. Application of external support bandaging to promote proper tissue alignment and healing, and administration of appropriate antibiotics to prevent infection. So here I'm just going to conclude the lecture with dentoalveolar fractures demand quick diagnosis and well-planned stepwise treatment to maintain tooth health, restore normal function, and avoid lasting complications. Accurate tree positioning, stabilization, and continued monitoring greatly enhances outcomes, whereas delays can result in permanent issues such as pulp death, bone resorption, or eventual tooth loss. Thank you so much. These are my dental page platforms. You can contact me whenever you want, and you can actually ask any question that you want to ask through these platforms. You can take a screenshot.
Thank you so much, Dr. Mariam Mostafa, for the insightful session. Your expertise and clear explanation have truly enriched our virtual summit 2025, and we are grateful for the time and effort you dedicated to sharing your knowledge with us today. To
Thank
our
you so
audience, we would love thank you. To our audience, we would love to hear your thoughts about today's session. Please take a moment to fill out the feedback form. Your response helps us improve and also serve as a token of appreciation to our speakers. The feedback form link is now in the chat box or comment section. Once again, thank you so much, Dr. Mariam, and thank you all participants for being here. And stay tuned for our next session coming up very shortly.
Assalamu alaikum. Welcome to the Maxillofacial Fracture Virtual Summit. On the behalf of the experienced dentistry team, we warmly welcome Dr. Shaheen Ahmed, BDS, FCPS, oral maxillofacial surgeon, and PhD in OMFS, and extend our the heartfelt gratitude for joining us as a distinguished speaker. We are truly honored to have such an accomplished oral and maxillofacial surgeon from the Dow University of Health Sciences share his expertise. His session, Mastering Mandibular Fracture from Planning to Plating, promises to offer invaluable insights and practical knowledge to the participants worldwide. Thank you, Dr. Shaheen.
First of all, I'm very thankful to the organizers for giving me this opportunity to be here in this Maxillofacial Virtual Summit. I'm very thankful to the organizers. So we have the time, so I can introduce myself. I am Dr. Shaheen Ahmed, working as an associate professor in the Department of Oral and Maxillofacial Surgery. I am head of the department as well in Dow National Dental College. And recently I did my PhD in oral and maxillofacial surgery, and I did my FCPS back in 2011 from CPSP, and I have did my part A of FFDRCS from Ireland recently in 2025. So I'm going for the part B in most probably in November for the FFDRCS exam. So I'm doing maxillofacial surgery for the last more than 15 years. Mostly I do the oral cancers, but I do the fractures as well because we have a long team with us. Most of the guys are doing the trauma and the cleft lip palate and orthodontic surgeries as well. So we have divided them into different categories so that we can do it. Let's start with the mandibular fractures. I am working as a associate professor in the Department of Oral Maxillofacial Surgery. Next change, please. First of all, for the mandibular fractures, for going to treat the mandibular fracture, you need to diagnose it first. And before diagnosing it, you need to understand the anatomy of that area as well. That is very important, the regional anatomy. Once you know the regional anatomy, then it's going to be easier for you to diagnose and treat properly. Can anyone change the slide, please?
Yes, sir.
So I cannot see the slide is changing. Can you see the slide is changing? Yeah, okay. Let's go on the anatomy on the third slide. Yeah, on the back. The previous one. So anatomy, basically the mandibular as a interface with the skull base through a temporomandibular joint that is a complex joint, and that and the mandible is being the weakest side from at the third molar in the canine region or in the condylar region as well. The three sides are very weak region to be fractured. And for the distribution of anatomy units for the mandible can be divided into the symphysis, the parasymphysis region, the body, the condyle, the coronoid region, and the angle. And the third molar area is the most weakest side to be fractured. That is the third molar area. Then the canine region, and then is the condylar region are the weakest point to be fractured whenever the mandible is being hit. So before going to the trauma, one should know about the innervation of the mandible. The mandible being innervated by the mandibular nerve that comes out from the skull through the foramen ovale, and it enters into the mandibular foramen as an inferior alveolar nerve, and it supplies the dental plexus, and as it comes out from the mental foramen as a mental nerve and supplies the incisor and the mental region as well. So this is basically anatomy of the mandibular foramen. So the blood supply of the mandible depends the supply by the internal maxillary artery, the branch of the external carotid artery, and it divides into gives the branch of inferior alveolar artery that enters into the mandibular foramen and supplies the mandible, and comes out from the mental as a mental artery, and supply divides into incisive and the mental artery. It supplies the tooth and the incisive region. Next slide, please. Next slide. Next slide, please. Next slide. Next. Yeah, this one. The anatomical considerations. Yeah, the previous one. Now the anatomical considerations. The previous one. Go to the previous one slide. Yeah, this one. The anatomical considerations are very important because there are a number of muscles being attached with the mandible that causes the favorable and the unfavorable fractures to be displaced or to be undisplaced. One should know about these anatomical considerations like the muscle of mastication, like masseter temporalis muscle, medial lateral muscles, malohead, genohead, genoglossus. They all are very important for the management of the mandibular fractures. So this is the international distribution. The study conducted like 20 years retrospective analysis. The next slide, please. That shows the distribution of the mandibular fracture and globally, not the local Pakistan data. That is from the USA. So you can see in that part of the world, the body fracture are very common. Then there is the symphysis and the angular condyle are almost the equal region. Now, the body part fracture is very important in that part of the world because the most common cause in that part of the world is assault. So whenever there is assault, there is a commonly there is a mandibular body fractures. Next slide, please. Now, this study is a local study from Pakistan that shows the distribution of the mandibular fractures. You can see in this part of the world, the parasymphysis fractures are very higher, 31%, and like the angle fracture, and then there is the condylar fractures are very important in this part of the world because of the road traffic accident. There are a number of causes. Next slide, please. There are a number of causes which are causes the mandibular fracture, out of which in the developing country, the road traffic accidents are the most common cause of the fractures. And in the developed country, the assault is the most common cause of the fractures out of it. And then the sports injuries, falls, and gunshot injuries are very important for the diagnosis of the mandibular fractures. Next slide, please. The mandibular fractures can be presented with a number of ways, like they may be isolated, maybe with the other facial bone fractures, like with the panfacial fractures, associated with the head injuries, cervical spine injuries, and if there is bilateral parasymphysis fractures that can compromise the airway as well. So you need to consider these things in mind. This is the isolated fracture or multiple fracture, or this is a panfacial fracture, or this is associated with the head injury, or can cause the airway destruction as well. So the mechanism, next slide please. The mechanism of fractures is whenever there is a force impact on the mandibular fracture, there is a compression and there is a tensile force on the lingual side. Once the tensile force is more than the compressive force, then there will be a fracture. The fracture starts on the lingual side and goes on to the buccal side. So buccal side is having the tensile strength, tensile force, and on the buccal side there is a compressive force being applied. So once the force is applied on the buccal side, on the lingual side, the tensile force generated. Once the tensile force is more than the compressive force, then that can cause the fracture, and the fracture starts from the lingual side and goes to the buccal side most commonly. Next slide, please. There are the number of fractures. They can be classified into according to the site, according to the type of fracture as well. According to the type of fractures, we have the simple fracture, the compound fracture, the green stick fractures, the comminuted and the pathological fractures can be classified into this. And according to the site, we can classify according to the symphysis, parasymphysis, body, angle, ramus, condyle, and subcondylar fractures can be divided into this type as well. Next slide, please. And for any fracture, the favorable and unfavorable concept is very important to understand. This concept is very important. This is basically the view you are looking for the fracture, the horizontal view and the vertical view. If the fracture is horizontally favorable or unfavorable, or vertically favorable or unfavorable. Next slide, please. There are some muscles pull which can cause the favorable fracture, the fracture to be reduced, And the muscle pull that can cause the unfavorable fracture muscle means the fracture is being displaced apart, or there will be a gap in the fracture. So this is called the unfavorable fracture. You can see in the first picture A, you can see the pull of the masseter muscle is reducing the fracture. This is called the favorable fracture. If it on the B picture, you can see the masseter muscle is pulling up, so it's causing the fracture apart, so it is an unfavorable fracture. So you are looking in the horizontal direction, then it's called the horizontal favorable or unfavorable. If you're looking in the vertical direction, then it's called the vertically favorable or unfavorable. You can see the angle fracture on the C picture. You can see the medial pterygoid and the lateral pterygoid pull can cause the fracture to be reduced. This is called the favorable fracture. On the other side, on the D picture, you can see because of the pull of the lateral pterygoid and the medial pterygoid can cause the fracture apart. Then it's called the unfavorable fracture. Next slide, please. So mandibular fractures are very often present fractures, mostly compromise the airway and elevated the risk of cervical spine injury as well. May have considered contaminated as well once they are being exposed to the exterior as well. The examination findings includes the immediate assessment of the patient like ABC, the general clinical examination, the local examination is very important. Next slide, please. Next slide, please. Yeah, general consultation, local examination is very important. And then local examination, next slide, please. So we can divide the patient into external examination and the intraoral examination. External examination, look for any laceration, any swelling, trismus. You can see here in this picture. Next slide, please. You can see there's a laceration on the chin side area. So this is a contaminated wound. So this need to be debrided first and then for the fixed side reduction as well. Next slide, please. The tenderness, the capitations, the nerve damage, hyposthesia, and the paresthesia are important. For the internal examination, we go for the check for the occlusion of the patient. It is dearranged or it is malocclusion. There will be any fracture site, any missing teeth, any lingual hematoma that is the sign for the fracture. If it is present on the lingual side, then there might be a upper fracture or the body fracture being present if there is a chymosis on the lingual side. Next slide, please. The additional concern, which are very important for the mandibular fractures, next slide, please, is the intoxication. Like the patient is having an alcoholic or the patient is having the head injury is very important. Cervical spine control is very important. Every patient should consider as a cervical spine injured patient whenever he is having a maxillofacial trauma. The glaucoma scale is very important. You should go for the glaucoma scale and then for the missing teeth. If there's teeth is missing, then you need to find out where the teeth is. It is in the GIT or in the respiratory tract. You need to find out that missing teeth as well. For the diagnosis of the mandibular fractures, the important thing is next slide, please. The important thing is the traditional X-rays are very important. So we'll start with traditional X-rays like the lateral oblique views, the PA mandible view, the reverse tones, the OPG are very important. They are the basic. Or once you have a complicated type of injury or high velocity injury, then you go for the CT and MRI. Chest radiographs we go whenever we haven't suspect any tooth in the chest or patient is having difficulty in breathing. So then we can go for the chest radiographs to rule out any clavicle injury or the rib injury as well. So the general management starts with the ABC management of the patient. The next slide, please. The tetanus injection should be given to the patient. The hemorrhagic control, stabilization of the patient, wound, and the reduction in mobilization is very important. And then there comes the very important part is the nutrition, and then the follow-up. If there is any teeth is missing, then you go for the rehabilitation of. So the treatment, general treatment, we go with the ABC, airway, breathing and circulation, the hemorrhagic control, stabilization of the fracture, and then fixation of that fracture and nutritional support as well. If there is a missing any teeth or the bone, then we go for the rehabilitation. Next slide, please. So not every mandibular fracture is being treated with the plating. With the plate, we will not apply the plates for every treatment. Next slide, please. The soft diet. If the patient is we can go for the close reduction. We can go with the open induction as well. So the you can go back, go back. Yeah, this reduction. Now, reduction treatment options are very important. Not every mandibular fracture is being treated. We go for the no treatment as well if the fracture is being undisplaced, or we can go with the closed reduction. We can go with the open induction with rigid and non-rigid fixation. I will tell you in detail about the these concepts of the closed and open induction. Next slide, please. The reduction is very important. The reduction means how you reduce the fracture. That is very important. Next slide, please. Uh, for reduction, you need to understand this is the first priority of the patient's occlusion. If the patient is in class 1, class 2, or class 3 or crossbite, uh, always look for the facets of the patients and try to replace that facets with the facets. Do not make it like the patient on a class 1 if the patient is not in on class 1. So it is not ideal to every patient to be in a class 1 occlusion. So if the patient is having the normal bite of class 2, then you need to place it on the patient on a class 2 as well. So next slide, please. So you need to understand the favorable fractures, non-displaced fractures, grossly comminuted type fractures, severely atrophic type fractures, or children's which having a developing dentation. Then you go for the closed reduction. Now, closed reduction means you are not seeing the fracture, you are not giving the incision at the fracture site, you're not anatomically reducing the fracture. So they are not anatomically reduced, but they are being, the occlusion is being on the normal side. So your assumption is that the fracture is being reduced anatomically once the teeth are in normal occlusion. This is called the closed reduction. Now, closed reductions, there are different methods of closed reduction, which includes the eyelets, which includes the arch bars, which includes the suspension wiring, and it depends upon the 3 weeks plus minus number of fractures being present. And for the children, we go for 7 to 10 days IMF in children less than 10 years of the age. Next slide, please. The advantages of the closed reductions are they are inexpensive and easily available and do not require general anesthesia. Next slide, please. There are a number of disadvantages like the fracture is not being reduced properly and non-compliance of the patient. If the patient is having a medical problem, then you are not being able to provide this closed reduction. The patient's mouth is being closed, so the patient can have a weight loss as well. The patient cannot eat properly. Next slide, please. Now, indication for the open reduction internal fixation, which includes the grossly comminuted type fractures, displaced fractures where the patient cannot be able to reproduce his occlusion, patient on comfort, patient is medically compromised where you cannot provide the closed reduction, then you can go for the open reduction as well. The advantages is this: you can provide the rigid fixation, patient can go early on the function, and patient the fracture is being reduced anatomically. The disadvantage is invasive procedure, it's expensive as well, and there's a potential chance of infection as well. And the cost is an important factor. Now, you can, the fixations can be given to the patient, and the type of open induction which we can give the fixation is the external fixators and the internal fixators. Nowadays, we are not using external fixation. In 1950s to 70, we were using that external fixators. Now we are using internal fixation as well. Now, internal fixation can be divided into, next slide, please. Internal fixations can simply imply the placement of the wire or the rods or the plates and screws, all are called the internal fixation. Next slide, please. Now, internal fixation can be a rigid fixation, can be a non-rigid fixation, can be a functional stable fixation. Now, rigid fixation means that there is no movements or no micro movements in the fracture side. If you are reducing the fractures, then there will be no micro movements on the fracture side. This is called the rigid internal fixation. For non-rigid fixation, there is a micro movements on the fracture side, like this transosseous wiring is being applied on the fracture side. There is a micro movements on the fracture side. Now, functionally stable, next is the functionally stable fixations, which includes the functional movements, which allows the functional movements during the function of the movements. Like when the patient is eating, then it's allow the functional movements for the patient, but fracture is stable, but they are functionally stable. So applying a single plate, mini plates are the example of functionally stable fixations. Next slide, please. These are the physiological stretches that can be applied on the mandibular, like tension zones and the neutral zone and compression zones. The functionally stable osteosynthesis are applied on the tension zone, and the rigid fixations are applied on the compression zones. Next slide, please. This is the Champy's principle that applies for the functionally stable osteosynthesis, which applies the tension zone. You can see on the anterior to the mental foramen, there are two lines which shows the tension zone, and on the body of the mandible and the angle of the mandible, you can see the two lines on the angle of the mandible. So this black line shows the tension zone and this functionally stable osteosynthesis. So mini plates, which are the non-rigid type or functionally stable osteosynthesis, applies on this Champy's principle on the tension zone. And for the compression zone on the lower border of the mandible is called the compression zone, where we can apply uh, uh, the rigid fixations. Next slide, please. You can see here the tension zone. The minus shows the tension zone and the plus shows the compression zone. The tension zone will open up the fracture and the compression zone will reduce the fractures. So whenever you apply a plate on the tension zone, it will reduce the fractures. If you apply a plate on the compression zone, it will not reduce the fracture. The compression means it's compressing the fractures together. The tension zone means it is opening the fractures. So the plate is being applied on the compression zone, on the tension zone. Next slide, please. Now, there is a concept of load-bearing area and the load-sharing areas. The load-bearing plates are those plates which are being thicker. They are more than 2 mm thickness, like 2.4, 2.6, 2.8 mm thickness, that can bear the forces. Load-sharing plates are those plates that share the load and they distribute the load on the mandible as well. And the load-bearing plates are the plates which bear all the loads on the load-bearing plates. Load-bearing plates are those plates that are more than 2 mm, like 2.4, 2.6, and 2.8. If it is below the 2 mm, then it's called the load-sharing plates. The load-sharing plates, they can apply on the simple linear fractures, like functionally stable fractures. The mini plates, the lag screws are the example of load-sharing fixations. The osteosynthesis means the fractures are being healed. It can be applied by the screws, that can be applied by the plates, and the plates can be compression plates, can be adaptation plates, can be universal plates. Adaptation plates can be mini and micro plates. Mostly we are using the mini and the micro plates nowadays. And for the compression plates, we use compression plates where their mandible is missing. When there is a missing bone, then we can go for the compression plates. Next slide, please. Now there are the types of screws, like mini plates, adaptational plates, mini plates, micro plates, and the screws, compression plates with the biocortical plates and lag screws. And the difference between the mini plates and, next slide please, the compression plate is the screws. The screw can go on the biocortical on the both, on the buccal side to the lingual side, then it's called the compression zone, and the bicortical plates. If it is on only one buccal cortical plate, then it's called the mini plates. Next slide, please. These are the compression plates. Next slide, please. These are the types of screws which we are using, like the self-tapping screws, the mini screws, and the locking screws as well. Next slide, please. These are the adaptation plates. Now we are widely using these adaptation plates with the screws as well, 1.5 and 2 mm of thickness with the micro plates, and these are the screws of this adaptation plates, and these are the heads, hexagonal and the crisscross type head of the screws. Next slide, please. Next slide. Next slide, please. Now this is the difference between the mid-face and the mandibular plate. The mandibular plate are slightly thicker, like 2.0 mm, and 1.5 mm is for the mini plates for the mid-face fractures. The screws are like for the different diameters as well for the adaptation plates whenever you're applying on the mandibular or on the mid-face. Next slide, please. So we are using this system as well for the screws and for the plating system as well, titanium plating. Next slide, please. Next slide, please. Next, please. Now, these are the dynamic compression plates which we are using it, where on the compression zone, not on the tension zone, firstly, and secondly, whenever there is a missing bone or whenever the height of the mandible is very low. So we apply these compression type of plates because they are the plates which bear the forces. So, and their screws are bicortical that goes from the buccal to the lingual cortex. Next slide, please. Next slide, please. Now this is the universal plates, which we have a plate thickness like 2 mm and the screws like 2.4 mm diameters. I showed you in the mini plates, and that is we are using it for the mini plates in the mandible. Next slide, please. This is the reconstruction plate we are using whenever there is a missing teeth or whenever we apply the free fibula or the iliac bone graft. We use the recon plate with that. It's like 2.5 mm, 2.4 mm thickness of the plate, and the screws. The basic principle is this plate is applied on the compression zone and 3 screws on each side of the fracture. Next slide, please. So these are the types of plating, locking, and the non-locking type of plates available. Next slide, please. This is the leg screw concepts. Leg screws can provide the rigid fixation, means there is no micro movements on the fracture sides, and it can be applied on the oblique fractures. Next slide, please. Sorry. This is the resolver plate system. We can apply this resolver plate on the children whenever there is a fracture on the children's. We can go for this resolvable plate system. This is the resolvable. You can see the mini plates and the resolvable plate comparison. The screw and the plate as well. You can see these are the resolvable plate that can be resolved, that can be applied to the children's only because their strength are not good. Next slide, please. These are the resolvable plate being applied to the fracture side in the children's. Next slide, please. Now, according to the type and management, this is symphyseal fracture. You can see, according to Champy's principle, we apply 2 plates on the symphyseal fracture or 2 leg screws on the, next slide, please, on the mandibular fracture for the symphyseal fracture. Next slide, please. Or we can apply the arch bar, different combinations, arch bar on the single plate as well, the reconstruction plate on the lower side. Next slide, please. For the community type of fractures, if you have a community type symphyseal fracture, we always go with the reconstruction of the locking plates so that we can have all the fractures being aligned together from a single plate and an arch bar on the upper side as well. Next slide, please. So we have this type of fracture as well. We can apply the locking plates and simple mini plates on the upper side as well. Next slide, please. These are the different variations you can apply depending on the types of fracture you can have in there. Next slide, please. Next slide. And for the angle fracture, we can apply a single plate on the angle fracture. We can apply the recon plate with the angle fracture depending upon the type of fracture as well. Next slide, please. If it is being community type of fracture, we can apply 2 plates. If it is single fracture, we can apply an intraoral incision with a single plate over the angle fracture. Next slide, please. If it is being a resorb ridge, we can apply the reconstruction plate. You can see here in this slide, this is the resorb ridge, and we can apply a reconstruction plate on this area. So if there is a tooth is missing and you have seen the extracted the tooth and the gap is very big on the upper side, you can apply the reconstruction plate on the lower border. But the reconstruction plate always apply on the compression zone. Next slide, please. These are the surgical approaches. We can divide them surgical approaches into extraoral and intraoral approaches. In the extraoral, we have the retromandibular and submental and the vertical vestibular incisions and retromandibular. And then we have the 3 types of retroperitoneal transparotid and transmesenteric approaches. And for the vestibular incision intraoral, we have the vestibular incision for the symphysis body and condyle fractures as well. Next slide, please. Now, selection of the surgical approaches can depend upon the level of the fracture, the existing laceration, the associated with the fractures, the surgical exposures needed, the cosmetic regions of the patients, and the method of fixation you apply. All those characteristics can guide you what type of incision and where you want to give the incision. Next slide, please. If the patient is having the existing laceration, you can go with you can follow the existing laceration. You can see here the patient is having the existing laceration. You can see in the 3D CT scan there is a communal type of fracture. So we apply a plate on the body and on the ramus as well, and on the parasympathetic region as well. So we follow the existing laceration in this case. Next slide, please. So you can see the existing laceration. You can see the occlusion. The intoral approaches. For the symphysis fractures, you can go for the intoral approaches. Vestibular incision given from canine to canine. Next slide, please. The vestibular incision is given from canine to canine region, and mucosa and submucosa are being cut, and then the mentalis muscle is being cut at 90 degrees with the mandible. Next slide, please. You can see the mentalis being cut at 90 degrees with the mandible. Next slide, please. And you have a closure with this. The mentalis muscle should be closed, and then the mucosa, then the vestibular incision should be closed. It's important to close the mentalis muscle because then it will cause the liptosis. Otherwise, cause the liptosis. You can see in this slide there is a parasympathetic fracture on this area. You can see, you can appreciate the fracture line. The two plates apply on the parasympathetic region. This is the mini plates. Next slide, please. Mini plates being applied on this fracture side. You can see the fracture is being anatomically reduced, and the two plates are being applied in that fracture side to reduce that fracture. Next slide, please. You can see the bilateral parasympathetic fracture in this slide, and the plating system is being applied. The four plates being applied on both sides. So the fracture is being reduced anatomically, and the plate is being placed here. Next slide, please. This is the post-op radiograph of the same patient showing the anatomical reduction with the plates as well. Next slide, please. Body. For body fracture, you need to understand the incision. It starts from the third molar region up to the canine region, and there you need to understand the mental nerve as well. To encounter the mental nerve, you need to identify the mental nerve and dissect it as well. Next slide, please. Next slide, please. You can see, next slide, you can see the mental nerve here. Here you can see the mental nerve which is being dissected from the fracture side. Next slide, please. The angle fracture, the vestibular incision on the external oblique ridge is given, and the fracture you can see here, the incision is given on the external oblique ridge. Next slide, please. Next slide, please. You can see the fracture on the angle side, and the external oblique ridge plate is being applied. Single plate is being applied. Mini plate is being applied on the external oblique ridge. Next slide, please. This is the occlusion of the same patient. Now this is the post-op X-ray of the same patient. Next slide, please. You can see the fracture reduction, and the third molar is not being extracted because that was reducing the fracture. Next slide, please. Sometimes you have a communal type of fracture. You can go with the trocar as well for applying the plating system. This is another method to apply the screws for the communal type of fractures. Next slide, please. These are the external approaches. For external approaches, you need to understand the regional anatomy of that area, that is the blood supply of that area, and the nerve as well, the external carotid artery, the branches, the marginal mandibular nerve. That is important. You need to understand the facial artery, the facial vein, and the marginal mandibular nerve for the external approaches. Next slide, please. This is the submental approach. You can see here the submental approach can be used as in the submental region. You can apply on this on the submental crease or in the chin area as well. Next slide, please. This is the exposure for the fracture on the symphysis region. Next slide, please. Submandibular incision should be given like 2 centimeter below the lower part of the mandible, and the fracture side is being exposed with facial artery being tight, and marginal mandible nerve should be saved in this scenario. Next slide, please. This is being exposed. Next slide, please. Now, for the condylar fracture, there are different approaches being used for the condylar fracture. One should know the regional anatomy of that area. The most important one is the facial nerve is very important whenever you're doing the condylar fractures in open reduction. So you need to understand the distance between the marginal mandibular, the buccal branch, and the marginal mandibular nerve, and you need to understand uh, the the location of this nerve. You can see here in this distances. Next slide, please. These are the distances, the 0.8 to 3.5 centimeter the main trunk from the temporal branch. So this area is very important to giving any incision is safe, like 0.8 to 3.5 centimeter and 2.4 to 3.5 centimeter in the depth. In this depth, so this area is the area where you can give the incision for preauricular or the temporal type of incision should be given here to avoid damaging the facial. The 0.8 to 3.5 centimeter area is the safe area from the external side to the to that area. So next slide, please. This is the another example of the distribution of the zygomatic nerve. You can see the distribution of the zygomatic nerve and the temporal branch by drawing a line from the canthus of the eye to the tragus of the ear. Next slide, please. This is the marginal mandibular nerve. Once you are doing for the submandibular approach, you need to understand this marginal mandibular nerve, how it runs, posterior to the facial artery and anterior to the facial artery. Mostly from posterior to the facial artery, 81% is at the level of the angle of the mandible, and like 18-19% is above the angle of the mandible. Once it is anterior to the facial artery, it is always above the mandibular, below the lower border of the mandible, above the lower border of the mandible. So this is the marginal mandibular nerve anatomical variations. So this is the basically the preauricular approach. You can see for the condylar fracture, the head, neck, and the subcondylar fractures. And for the head and neck fractures, we go for the preauricular approach, and for the subcondylar fracture, we can go with the retromandibular or the transparotid approaches as well, or endoscopic or intoral as well. Next slide, please. These are the different approaches like endoral, preauricular, retromandibular, and the submandibular as well. Next slide, please. The preauricular approach is very important. You can see here in the diagrammatic representation and in the clinical picture as well. It's from tragus to the from the helical, and skin and subcutaneous tissue being exposed. Next slide, please. You can see it goes up to the temporalis fascia. What I was telling you about the 0.8 to 3.5 centimeters, this area is the safe area. You can cut the incision from the temporalis fascia here, so that the facial nerve should be safe. The facial nerve runs over the fascia. Once you cut this fascia, you go below this fascia. So you can see here the temporal branch is above that fascia, and you are below that fascia. Next slide, please. So by exposing that, you can expose the condylar head. Next slide, please. You can expose the condylar head, and you can apply the plates here in this area. You can see here in the clinical picture, you can see the fracture is being exposed, and the plate, you can see the plate here in the preauricular region. Next slide, please. And this is being closed as well. Next slide, please. This is the retromandibular transparotid approaches. This is used for the low condylar fractures, and this is like 2.5 to 0.5 centimeter below the tragus of the ear, and just below the angle of the mandible, reaching up to the angle of the mandible. So you can give the skin subcutaneous tissue, then you have a smash layer, cut the smash layer, you can go into the parotid, dissect along the direction of the facial nerve, blunt dissection in the facial nerve. You can see the parotid fascia is being cut and dissect along the direction of the facial nerve. Then you can expose this. Next slide, please. This clinical picture shows the exposure of the condylar fracture. You can see the fracture being reduced, and the plate is being placed here. You can see the next slide, please. You can see the two plates being placed on the condyle, and the fracture is being closed with the subcuticular closures. Next slide, please. This is retroperitoneal approach. This is beyond you coming out. Uh, uh, Previously, we are going through the parotid. Now that is coming out below the parotid, and we go beyond the parotid as well. Skin and subcutaneous tissue is being cut in this layer, and you dissect uh, the fascia and goes to direct to the the masseter muscle, and you retract the parotid gland upward direction. Here you can see the parotid being retracted upward and the fracture is being exposed in the retroparotid approach. In this approach, you will not cut the parotid gland. So you can see here the fracture is being reduced and fixed with this approach. You can see here the retromandibular transparotid approach. You can see here the cut. This is the anteroparotid transmasseteric approach. Here the incision is giving in this, but the fascia is being cut anteriorly at the masseter region. You can see here the fascia is being cut, the muscle is being cut anteriorly, anterior to the parotid. You can see the fracture is being reduced and played. You can see a very small incision in this. Next slide, please. These are the exposures which can be provided by the preauricular. Preauricular can give only the incision. Next slide, please. Can give the exposure to the condylar head region or the neck region, and for the retromandibular approach can give the incision up to this. Now, this is the approach where on which I am doing most of the cases. This is the new approach, inferoparotid transmasseteric approach. What I prefer to do is this. In this approach, on the retroparotid transmasseteric approach, you can see here. Next slide, please. You can see a yellow line here. This is the retroparotid transparotid approach. Next slide, please. Next slide. You can see here the red line, which shows the transparotid approach, and the other slide show the transmasseteric approach. And my approach is like on this anterior masseteric approach. Next slide, please. Next slide. You can see this is the yellow line in the retroparotid transparotid approach. Next slide, please. The red line shows the transparotid approach. And next slide, please. The blue line shows the anteroparotid transmasseteric approach. And you can go back. The green line shows the inferoparotid transmasseteric from where we are doing it. Like you can see the facial nerve here. In this slide, you can see the facial nerve, the buccal branch, and in the marginal mandibular nerve. You can see here. Next slide, please. Next slide. There is a gap in between the marginal mandibular and the buccal branch. So we use this area to avoid damaging the facial nerve, and we go inferiorly from the parotid gland. You can see here on the next slide, you can see the star in this area. Next slide, please. You can see the star. This star shows the area which we are involved, which we're going to use for the in between the buccal branch and the marginal mandibular nerve. Next slide, please. Now the incision is giving 0.5 centimeter below the ear tragus. The skin subcutaneous tissue is being exposed. You can see the skin and subcutaneous tissue is being exposed. You can see the smash layer. Next slide, please. You can see the smash layer. Smash layer is being exposed, but the parotid is not being cut here. Next slide, please. You can see the parotid gland is being not cut, but smash layer is being cut, and you can see the muscle in the background. You can see the muscle. So we cut the muscle in that area, in this direction. You can see the sling. Next slide, please. Next slide. You can see the pterygomasseteric sling. We cut the pterygomasseteric sling. Next slide, please. Now you are on the mandible. So we reflect it in upward direction. So we reflect all the tissue in upward direction towards the condyle, and all of the tissue is being retracted. You can see here. The next slide, please. Is being retracted upward, and the two plates are being applied. For a gunshot injuries, where they are different ball game, and they are different, being managed differently. But I will touch only few of the cases. Like this is one of the cases of gunshot injury. If it is the fracture is being non-infected, or there is a less amount of bone being avulsed and soft tissues being present, then you can go for the early reduction and stabilization. If it is soft tissue being avulsed or there is infected wound, then we can go for the delayed type of reconstruction of that gunshot wound. So this is the, hopefully that patient is having no soft tissue injury. So we applied the recon plate here in this next slide, please. The recon plate, and the fracture is being reduced, and the recon plate is being applied in this case for the gunshot wound. Not always we apply the reconstruction plates. The unusual cases you can have encountered is sometimes you extract the tooth, the third molar, you want to go for the extraction of third molar, and you end up with this. Next slide, please. And you apply too much force, then you end up with this type of fracture of the angle. You can see here the angle fracture. Now the two plates are being applied because of the gap is very bigger. So we apply two plates, one on the external oblique ridge and the other one is in the lower border, so that we can stabilize the fracture. So these are, next slide please. Next slide please. These are some of the cases which shows the angle fracture and the parasympathetic combination fractures, like the angle and the condyle, and with this we applied the plates in this previously. Go back, please. Yeah, this one. You can see here the patient is having the angle fracture and the patient is having the parasympathetic with the multiple fractures. So we applied the plate here on the parasympathetic and the angle fracture. You can see the occlusion. You can see the post-op X-ray as well. Next slide, please. This patient is having isolated condylar fracture and the symphysis fracture as well. So we apply two plates on the condyle and two plates on the parasympathetic fracture as well. You can see here in this scenario as well. Next slide, please. Now this patient is having the isolated condylar fracture. So we apply two plates, this lady. So we apply two plates on this condylar fracture. You can see the post-op occlusion and the plating plate as well. Next slide, please. Now these are the indication for the open reduction and the closed reduction. I'm not going in detail. These are the absolute and the content and the relative indication. Next slide, please. Condylar fracture can be managed by intraoral approaches, by the extraoral approaches as well. Next slide, please. So special considerations can be given to the pediatric fractures, because they have the deciduous versus permanent teeth. You are not being able to apply the plating on that because they have the tooth birds in that mandible, and they have the growth center as well. So you don't want to disturb the growth birds, you don't want to disturb the growth centers. So that is why you apply the circummandibular wiring. You apply for the closed reduction like circummandibular wiring, like the splint, or you can apply for the resorbital plates as well in the pediatric patients. So these are the distribution of primary, secondary molar. Next slide, please. Pediatric growth of the pediatric fractures, mandible. Next slide, please. So mostly we treat the condylar fracture for the children's fractures with the closed reduction. Open reduction can be applied once there is no tooth burn in that area, or we can apply in the lower border plating as well. So we can apply with the resorbital plates as well. Next slide, please. So we can go with the splint fabrication for that for the children as well. Next slide, please. So this is the method of applying the splint, placing the splint, and we can apply the splint on the child's fracture as well, which is being stabilized with the help of circummandibular wiring. That is under the general anesthesia. Next slide, please. For the resorb ridges, we can go for the next slide, please. For the resorb ridges, we can edentulous patient, we can go with the dentures, we can go with the splint type, we can go with the cutting type of splint as well. Next slide, please. We use this cutting splint as well for the edentulous patient, if the patient is edentulous. Next slide, please. These are the complications which, whenever you're doing the fractures, you always be encountering the complications. Now, complications can be early, can be delayed, can be soft tissue related, can be hard tissue related, can be related to the hardware which you are using, like the titanium plates. That can be like infection, malocclusion, non-union, delayed union. Sometimes the patient is having a TMJ problems as well. So whenever you're doing this type of treatment, you need to understand the complications as well. Next slide, please. Next slide, please. So you need to avoid that complications. You need to understand the proper diagnosis of the patient. Next slide, please. The proper diagnosis, the proper planning of the patient. Next slide, please. Consider comorbidity of the patient. And now, if you do not do the previous slide, please. Previous slide, please. Now, if you are not doing the fracture proper planning, then you end up with this type of thing. So you can apply the arch bar, but there is still the fracture is not being reduced. Next slide, please. You can see the plate is being applied, but the plate are not in the proper position. On the right side, you can see it is not involving the fracture. On the left side, it is not reducing the fracture, it's being overlapped. So if there is a proper planning and proper understanding of 1 hour can save you from the 1 month complication. So always need to be understand the proper planning of the patient. Uh, Thank you so much. I really appreciate your patience and the time you given to me. I'm very thankful for the organizers for Maxillofacial Summit units. I wish you best of luck for the rest of your summit, and I'm very thankful for inviting me, for giving me this lecture. I really appreciate your effort, and I'm very thankful to all of you. If you have any questions, I'm here. I can answer whatever you want to ask me. Thank you so much.
Thank you so much, Dr. Shaheen, for sharing your insightful session with us. And we are now open to questions. You can drop in the comment box. Dr. Shaheen, I have some questions.
Yeah, definitely.
Basically, you told कि हम जब थर्ड मोलर निकाल रहे होते हैं तो लाइक अगर ज़्यादा फोर्स हम लगा दें तो मैंडिबल ब्रेक होने का और उसका फ्रैक्चर होने का वो होता है, खदशा होता है. तो
जी
what
जी.
are the indications to use surgical drill, or what are the contraindications of it?
So you need to understand this. The position of the third molar is very important. If it is like close to the lower border of the mandible, or it is close in proximity with the inferior nerve, or it is like full bony impaction, then definitely you should not go for the extraction. You should remember the tooth belongs to maxillofacial surgeon and the bone belongs to the patient. So you need to make pieces of the tooth, not the bone. So cut the bone as it is required, not the overcutting of the bone. Or cut the tooth. The tooth belongs to maxillofacial surgeon. So you need to make it into 5 pieces, 10 pieces, 20 pieces. If the tooth is not coming out, make the pieces of the tooth, not the pieces of the bone. So remember that. So once you understand this, then you will not be able to damage the bone. So you need to understand what type of tooth it is and where it is present. And you need to understand your skills as well. You can do the extraction or you can't do the extraction.
Okay, so there is a question from Mansoor Ahmed. How
Yeah.
to select type of suture?
Yeah, it depends. It depends. Like in the intraoral, we prefer going for the 3-0 silk suture because the strength of the silk is very good. But this is the multi-filament and then can cause the infection as well. But you can remove it in 7 to 10 days. If the patient is like not coming back or patient does not want to be removed, then you can go for the Vicryl or 3-0 Vicryl as well. They have the same strength like uh, the silk suture. So you can go with the Vicryl or the silk suture.
Okay, so again, Mansoor Ahmed has asked that one of the slides show mental nerve. What's the reason?
Show the mental nerve. Yeah, whenever there is a fracture in the parasympathetic region or in the body region, you need to expose that mental foramen, because if you are doing blindly, you can damage the mental nerve. So you need to expose the mental foramen.
Okay. Vijay Kumar Bijil has asked, Sir, अगर gunshot may cross both sides of mandible bone, then how can we manage that case?
It depends. It depends upon if the both side of the bone is being missing or being avulsed. If it is non-infected and the soft tissue is being present, then you can go for the primary reduction of that side, and you can go with the reconstruction plate. You can apply the recon. You can apply the iliac graft or the free fibula if it is non-infected. If it is infected or there is a soft tissue damage, then you can go with the arch bar to stabilize that fracture. You can go with external pin fixation as well to stabilize that component, and you go for the debridement once the fracture is being non-infected, and then you can go with the delayed type of reconstruction, like with the free fibula with soft tissue and the hard tissue at the same time.
Okay. We have another question. What is reverse Downey's radiograph? And also, can you please explain Jamie's principle again?
Yeah, the reverse stone is basically used for the condylar fractures, and we can go for the condylar fracture once if you do not have the OPG or PA mandible facility. Then you can go with the reverse stone radiography, which is simple, easier, and you can see the condyle in that area, in that type of fractures where it's being displaced or undisplaced. Now, Champy's principle is basically shows the a tension zone in the mandible where you can apply the plates, the mini plates. So when in the anterior to the ventral foramen, there are two lines. That is the torsional forces and the tension zone as well. In the just below the apex of the teeth, this is the tension zone, and the lower border there is the torsional zone, torsional forces. So to counteract that, we need to place two plates adhere to the mental foramen. For mental foramen up to from mental foramen to the angle of the mandible, there is the tension zone only present on the just above the inferior alveolar nerve, just below the apex of the tooth roots. So we apply single plate in that area, the Champy's principle, when the third molar area, like the angle fracture, like the body fractures. So for this, we need to apply two plates on the symphysis and the parasymphysis region because of the Champy's principle and with torsional forces as well. For the body fracture and the angle fracture, we need to give one single plate on the tension zone. The upper border is called the tension zone and the lower border is called the compression zone. So whenever you are applying the mini plates, you always go for the tension zone, and whenever you apply the plates on the compression zone, you apply for the reconstruction type of plates on the compression zones.
Okay. So Mansoor Ahmed is saying that my question was why we do mental nerve dissection.
To expose the ventral nerve because to avoid damaging the ventral nerve. Once you dissect it from the soft tissue, then you have a more chance to retract the soft tissue. Once you are retracting the soft tissue, you might damage the ventral nerve. You do not dissect it from the soft tissue.
I hope that answers you, Mansoor. Sir, I have another question. Sir, in your experience, what are the key radiographic findings that significantly influence your surgical planning for mandible fracture?
Now, the most important thing is the important thing is about the occlusion is very important, and the fracture side. Always go for the two fractures right angle to each. Always go with two X-rays right angle to each other. So you can give the favorable and unfavorable fractures and the displacement of the fractures. You can say about that if you have two angle X-rays right angle to each other. So the occlusion, number one. Number two is the displacement of the fracture is very important. One for in the X-rays that will drive you towards the treatment options. That you need to apply two plates or a single plate, because if the comminuted type of fracture or a multiple fracture, you need to apply two plates. Sometimes you need to give two plates to stabilize that fracture.
Okay. Thank you so much, sir. Thank you so
Thank
much
you so
once
much.
again, Dr. Shaheen, for being with us and sharing your knowledge and your experience. On behalf of Experience Dentistry and all participants would truly appreciate. Dr. Mansoor Ahmed is saying thank you. Abdul Hafiz was saying previously it was amazing session. We have a lot of positive feedback, and I would like all the participants to fill the feedback form which have been shared in the comment section. This will ensure that you will get the certificate of participation and being a great audience today. Thank you so much. Now I'll give the floor to Dr. Adan Zahoor, CEO of Experience Dentistry, for today's closing remarks. Dr. Adan, the stage is all yours.
Thank you so much. Thank you so much, sir, for the insightful session. Assalamu alaikum, everyone. On behalf of Experienced Dentistry, I sincerely thank our speaker, guests, and participants for making Pakistan's first virtual summit on maxillofacial fractures a success. Today, we not only shared knowledge but also strengthened our collective resolve to ensure timely, effective, and compassionate care for facial trauma patients. May this be the beginning of ongoing learning and collaboration for the betterment of our community. Jazakallah khair, Allah Hafiz. Thank you
Allah
so
Hafiz,
much.
everyone.
Thank you so
Allah
much. Thank
Hafiz.
you.